Hello and welcome to a new episode of Home of Medicine podcast in association with RCP Edinburgh. My name is Dr. Ben Lovell and I am a consultant in acute medicine working in London. And here is my wonderful co-host.
Hi, I'm Dr. Amie Burbridge.
Right, Amie, it's my turn to present a case to you. This is a case where you are the post-take consultant on the medical take, and this case is being presented to you by a resident doctor who's clerked the patient who is presented today in ED. So, this is a 34-year-old man. Reason for presentation, generally unwell for 6 weeks. And to be more specific, intermittent fevers, fatigue, loss of energy, loss of appetite. He says he had the flu 6 weeks ago and just never shook it off. And he's felt rubbish with it ever since. And the reason for presentation today is that the last 2 days, he started to feel more breathless and generally just awful. And he's had enough. There you go. That's the presenting complaint. Anything particular that you're thinking there?
Okay, so 35-year-old male, normally fit and well, but has been unwell for 6 weeks. Fever, fatigue, low energy, low appetite, and he's had the flu. And he's now breathless and short of breath. Okay, so I'm going to be thinking, is there a post-infective syndrome? Is this post-viral infection, post-viral syndrome? Is this a respiratory condition? Has he got a pneumonia from his recent infection that has not been treated appropriately or has basically post-viral bacterial infection in the lungs? Shortness of breath, breathless, recent infection. Could this be a PE? Chronic infection or chronically unwell, is he anemic? Is he iron deficient? Is that why he's short of breath? Is that why he's breathless? Is that why he's tired? Is this an anemia? Whenever I see these sort of 6-week histories, I think, could this be malignancy? So is there something else going on here? Is there a lymphoma, a leukemia, a malignancy elsewhere? Because of the constellation of symptoms and how long it's been going on, am I going to be thinking about some sort of underlying rheumatological condition? Could this be vasculitis? Could this be... I mean, it's unlikely, but it could be. So those are the sort of things that are going through my head at the moment.
So I've written down here, based on 1 or 2 sentences, you've got partially treated pneumonia, PE, anemia, malignancy, favouring hematological, considering his sort of demographics, vasculitis, nothing. Do you know what would be really interesting is if AI or something could make a visual representation of our brains as we sort of go through things, and then like word clouds dynamically changing, and then things getting crossed out and disappearing, and new diagnosis coming on. That'd be quite cinematic and interesting, I think. Anyway, back to the story. I think that's really good. I thought PE. I thought flu. He said 6 weeks ago he had the flu, never got better. But what happened? I suppose the last 2 days, maybe he had a pee and that's what's going on here. But 6 weeks of feeling dreadful, it is interesting with intermittent fevers as well. But we need more information, I think. Rest of the history, past medical history, nil. It's a fit and well 34-year-old. Doesn't take any regular medication, has no allergies. Socially, he lives in a flat share with a couple of mates. He's a graphic designer. He socially drinks alcohol and he's a social smoker, maybe a few cigarettes a week, and also vapes. And then coming to examination, he's febrile at 38.1 degrees. His heart rate's 105 sinus. Blood pressure's 116/68. Respiratory rate's 18 and his SAT's a 97% on air. That was his booking in observations. So he is febrile. He says he had intermittent fevers for 6 weeks and he's febrile at the moment, which is interesting. There is inflammation afoot. Whether it's also infection is yet to be seen. But there is an inflammatory response going on here to something. So then we play the game of hunt the infection. His chest is clear to examination. He has no signs of peripheral edema, no clinical DVT, JVP is nice and flat. Abdomen is completely soft and non-tender, and he's a slim chap. No rashes anywhere. And all other neurological examination was normal, essentially. Does that put you anywhere useful now, or has that ruled out some things or ruled in some other things?
Has he lost any weight?
He feels like he has lost a bit of weight, but he cannot quantify it. But he says certainly he's been off his food.
And any night sweats?
He has actually had some night sweats. He feels quite hot overnight. What are you thinking about?
I was thinking of these symptoms for lymphoma.
Mm-hmm.
Was going through my mind. Has he noticed any lumps and bumps?
He has not noticed any lumps and bumps.
Any itchy skin?
No.
Okay. Is he sexually active?
I didn't have that information at the point of presentation, but you know that's something. So when you went to post-take the patient, this is something you'd be asking. Okay. Anything else?
Any recent travel?
Oh, okay. So we'll go and ask that at our post-take ward round. Yeah.
Mm-hmm.
Anything else we need to ask on the post-take?
Any recreational drugs?
Rec drugs. Okay. And what are you thinking about in sexually active recent travel recreational drugs? What are you screening for?
HIV.
Okay.
Could this be HIV seroconversion? Some of the symptoms that you described could be that. Travel. Has he been abroad recently? Has he been exposed to TB? He lives in a flat share. Has he been anywhere where he could be exposed to? I'm just trying to think. Actually, any other travel? 6 weeks. And recreational drugs. You know, is he taking amphetamines that could be causing the weight loss, the fever, the tachycardia? So I know they're a bit of a stretch, but you know, they could potentially be there. So
why is it a stretch?
Well, it's quite. I'm just thinking it's probably not going to happen, and I'm probably overthinking things.
Why is it not going to happen? Well, sorry, I'm not sure what you mean.
Well, because I do things so in depth sometimes. I'm like, is he really going to have TB? Is he really going to be on amphetamines that's caused these symptoms? You know, sometimes do I need to strip you back to basics and rule out common?
All right then. So I went to post-take the chap, and he didn't look very well. But you don't when you got the flu. But he looked over it, as the kids say. He looked tired, fed up, a slight glistening sheen to his skin. He looked sallow. He looked pale. What else to say? Yeah, he was mildly tachycardic. He was no longer febrile because he'd had paracetamol in the ED. And I did ask whether he was sexually active. He says not in the preceding 6 months. I asked about recent travel, and that was a no. Admittedly, I did not ask if he took recreational drugs. Apologies. And I re-listened to the chest, and yet it was clear. I mean, when we see people with infection, I feel like this is numbers out top of my head. I don't have data, but I feel like we look for chest and urine quite commonly as the big ones. And his chest was clear, and there was a chest X-ray for me to look at, which was clear as you like. And he denied any dysuria. UTI is very uncommon in a 34-year-old man, but he denied any sort of signs and symptoms of that as well. And I really pressed on his tummy, any secret abdominal abscesses I need to know about, but there was nothing there really. And his skin was all completely normal to examination as well. Gosh, do I send him home or do I bring him in?
Ooh, I wouldn't send him home. Because, I mean, I'd like to do some blood tests.
Oh, okay. CRP 96.
Okay.
HB 112. Platelets 213. White cells 14, 14. Neutrophils for 12. His urea and electrolytes were completely normal.
Lymphocyte count?
Lymphocyte count was 1.1. It was normal. And I did dip his urine, and the only thing that showed up, it was negative for nitrites, negative for white cells, 2+ of blood, and that was it.
LFTs?
LFTs were normal.
Okay.
Coag was normal.
VBG?
VBG showed a normal lactate of less than 2.
And glucose was normal?
Yes.
ECG was normal?
A mild sinus tachycardia, but nothing else on it.
HIV test?
HIV test, which we do a standard actually on
Yeah.
patients on the take. Yeah. So it came back negative.
Okay. Blood cultures?
We're done and sent,
Yep.
but not available on day of presentation.
Okay. And did you send a urine culture as well?
I didn't actually, because there was nothing on the initial screen that made me want to look for you. Yeah, bacteriuria.
So you did. So, but he's still short of breath, isn't he? But he's 97% on air.
Yeah, respiratory rate's 18.
Oh, would you do POCUS of the lungs?
I wouldn't, because I don't know how.
Nope.
But somebody else might do. And what are you looking for?
So I mean, I've keep whittering on about this because it's my newfound skill. So often when you find a chest X-ray which is completely normal, because you're not looking at the whole of the chest, I find that POCUS, thoracic POCUS, can be really helpful because sometimes you pick up on infections. You might see hepatization of the lungs, which suggests pneumonia. You might see small pleural effusions that you haven't picked up on the chest X-ray. So actually, sometimes it can be very helpful where chest X-ray hasn't been. So that might be an option.
Mm-hmm. I think we've done an episode maybe about hidden pneumonias, which are sort of only visible on POCUS, right at the posterior part of the lung behind the diaphragm, not visible on the AP side.
Absolutely. Dear, what would I do? So he's got a slightly high white cell count. He's got a neutrophilia. His hemoglobin is on the lower side of normal. Waiting for blood cultures, liver's normal, chest X-ray. I would look at his lungs. Would I admit? Would I send him home? Would you do a D-dimer? Would you do a CTPA? I mean, I think a D-dimer, the Wells score is, you probably think this is infection is going to be a higher than a PE. So I don't think you're going to do a D-dimer anyway. And also it's got inflammatory process going on, so it's probably not relevant. Would you do a CTPA? He's tachycardic, recently unwell. I might,
That's a reasonable shout, actually.
I mean, I'm not saying it's the right thing to do, but I mean, you could do ANCA, ANA, complement levels, ESR, plasma viscosity, serum immunoglobulins because of the slightly high CRP and white cells, looking at vasculitis. I find these cases really difficult because they're just quite tricky to really understand what's going on, and I can have a tendency to either under-investigate or over-investigate. And what's the middle ground? What's the compromise? What should I be doing and what shouldn't I be doing?
I'm deliberately being very quiet. So I'm letting you think it out.
I know.
I'm giving nothing away.
I feel like I'm in a therapy session where you just end up talking.
Staring at you.
Staring at me. Do you know what? Okay. I'm going to give some antibiotics. I'm going to give some oral antibiotics. And I'm going to do POCUS of the lungs. And at the moment, I'm not going to do a CTPA, but I'm certainly considering it.
Okay. So what oral antibiotic are you giving?
Amoxicillin, 500 milligrams TDS.
Okay.
If he's not allergic to anything, which he said he wasn't. I guess he did have an atypical infection. I'm going to go with amoxicillin.
Okay. My view, as it often is on patients who I cannot find a source of infection for, is let's watch and wait, and it may declare itself. And I think we have done a couple of episodes about this, where on day 2, whoops, oh my gosh, look at this pneumonia, or look at this, I don't know, this nephritis or something. So I said, let's bring him in, give him something broad spectrum. I went for IV Kef, which is our broad spectrum, which is our antibiotic for infection of unknown source. And I say, let's sit on him overnight, take lots of blood cultures, and let's see what will be. And I brought him in, and I saw him again the next morning. And interestingly, the next day, his CRP had gone up to 150. He was persistently febrile. But otherwise, he looked similar to as I saw him before. And I think it was close of play on day 2, where I was like, I'm really not sure what the direction of travel is for this man. I went to our morning MDT. Everyone wants to know what's the estimated discharge date for all your patients. I'm like, for him, just say 2 days because I don't know yet. I've not made the diagnosis. We're still treating him with vitamin T, which is time, and we will see what happens. And I think it was closer play that we got the phone call from Micro, and they said that all 3 of his blood culture bottles have grown the same bug, Staph aureus.
Do you know, I knew you were going to say Staph aureus.
Did you? How?
Because I've been thinking endocarditis.
Why?
Because it came into my head about 1 minute ago. And
I mean, that's great, but why? What's the reason? People have been listening going, why did it come into your head? Why did your conscious produce endocarditis? It must have had some data.
Because, okay, so I was thinking, this sounds vasculitic. Endocarditis is a vasculitic process. It's been going on for 6 weeks. He's been losing weight. He's been fatigued. His CRP is slightly up. His platelets are a little bit low. White cell count neutrophils are a bit high. A bit short of breath. It just thought, this could be endocarditis, infective endocarditis.
And Staph aureus, what do you make of that as a potential causative organism for Staph aureus? For endocarditis.
It's not common, is it, actually? It's more common in drug users. So it could still not be endocarditis. But now I'd start to look for endocarditis. I'd want to do an echo. I'd want to look at his heart. But you said there was no heart murmur, but it doesn't necessarily mean...
I didn't say that. I did not say that. I said nothing about his heart sounds.
What?
Because heart sounds were not presented to me on the post-take ward round, and I didn't listen to the heart on the post-take ward round.
Okay, so this could be endocarditis. He could have a murmur. Let's listen to his heart.
So I go to the bedside. I listen to his heart, and he's got a pansystolic murmur, which was not picked up by the clerking doctor and was not picked up by my good self, because I don't always completely re-examine a patient at the post-take round if I think I've had enough information for what I need to move forward, and that we can talk about that maybe. And we did manage to arrange an echo, and the echo showed vegetation on the tricuspid valve with moderate associated TR.
Was he a drug user, an intravenous drug user?
I hadn't asked him, had I?
No, you didn't ask about recreational drugs, travel, or sexual activity.
I went back and asked about sexual activity and travel. I didn't ask about recreational drugs because this is a fit and well 34-year-old highly educated graphic designer. I was sort of pushing you a little bit because you said, oh, maybe I'm being a bit silly. It's not likely. And I was trying to sort of pick up why is it unlikely this man might take recreational drugs. And I was wondering if you were thinking the same thing I was subconsciously thinking.
I probably was.
But let's get down to it. So he gets diagnosed with tricuspid valve endocarditis. He gets placed on our standard endocarditis regime, which was, I think, amoxicillin, flucloxacillin, and gentamicin. He has a murmur, he has a vegetation on transthoracic echo. And then on questioning, this man does inject heroin, off and on, and has done so for many months. I didn't know because I didn't ask, because of my own representative bias, which is a very fancy name for saying lazy stereotyping then. This man couldn't be an intravenous drug user. He's a well-educated gentleman who has got a high-pressure job, turns up for work every day, is very articulate and very convincing of himself. Probably I don't need to ask about, does he inject opiates on a regular basis? And there was the hole. The other Swiss cheese hole was the lack of murmur detection at the point of clerking. And that's why he got cefuroxime for 24 hours, which is not the right antibiotic for what he had, and caused a little bit of delay in getting to his diagnosis. He did not have any splinter hemorrhages or any clubbing, but I thought it was worthy of reflection because I could have clinched this diagnosis in A&E if I'd asked the right questions and used my stethoscope in the right direction. But I didn't, because I clearly have a bias, an archetype. Let's call it an archetype because that sounds nicer than a stereotype, about someone who uses intravenous drugs, and he did not match it. Therefore, I did not pursue it. You wanted to ask about recreational drugs. So clearly you suspect anybody's potentially to be a drug user. But it did not fit my own representative bias for this particular patient. And that's something that I've been thinking about a lot ever since then.
Did you go into his drug use a little bit more with him?
I did a little bit. It was something him and his flatmates were doing, off and on. They didn't consider themselves to be drug addicts because they didn't do it regularly. It was just when they wanted to party.
Wow.
Yeah.
So inject heroin. Wow. Okay. That's new for me. Okay. Thank you. Because I guess I always thought that if you used heroin, because it was so addictive, you'd start to use it more and more and more and more, and it wouldn't be easy to not take. But I don't know.
But I mean, there are functional addicts out there who can hide it, who do take on the daily. And I guess there are people who socially shoot up. But it was something I wasn't very familiar with.
Gosh. Wow. And recovery from the infection, how did he get on? What was his valve like?
It was not in a good state, and this gentleman eventually got referred to our tertiary cardiothoracics unit for a valve replacement because the tricuspid valve was partially destroyed.
Gosh.
Yep. So he had surgery and made a good recovery as far as I can make out. And I don't think that the 24-hour delay after 6 weeks of vegetation caused any harm or outcome to him. But I think it was a good learning case, and I very deliberately didn't tell you about his murmur on the examination because I wasn't told about it. Not deliberately, I just wasn't told about it. So my brain clicked over it. And I was intrigued back that when you were recounting the case just now to yourself, you said, so he hasn't got any murmurs on auscultation. And I think that's important. That's not true. I just didn't tell you about his heart examination. And it's interesting how by not getting that information, our brain sort of synthesizes it as then the sign wasn't present. Part of our jobs as consultants on the post-take ward round is to listen incredibly carefully, spot gaps, and just say, sorry, murmurs? Anything on heart examination? And things like that, just so we can fill in any tiny little gaps in the history, which I hadn't done in that case. Because if we don't, then maybe our subconscious could fill in the gaps for us. And we assume if it ain't mentioned, it's because it wasn't there. But we need to hear that it's not there. Do you know what I mean? This is the art of post-taking. I never got taught how to post-take a patient. I'm sort of had to invent my own way of doing it, as all acute consultants do. But this was a learning point for me about how I conduct my post-take ward rounds.
And I certainly do them very different, I think, to you. I think I need to learn from you, actually, Ben, because I don't think my post-take ward rounds are particularly good. I'm so slow. I've talked about this before. I have to take the history and re-examine everything and everyone. And it paralyzes me. Like, I'm just, I'm overwhelmed by post-taking now. Maybe I've been doing it for such a long time that I need a break from the post-take. I don't know. In acute medicine, that's what we do, isn't it? Day in, day out, we are post-take. That's exactly what we do. And I think it's really difficult cognitively every day to see new patients, because every day we hear new histories, take on all this information, and there's so much to synthesize and so many decisions to make because nothing's been made for us so far. We are the decision maker, and that can be really difficult sometimes.
It also requires a large amount of trust. You say you're very slow. I'm very, very fast. And that's not because that's not better, but that's, I take a lot on faith. And I say, so you're telling me you detected X and Y, this is the blood, this is the X-ray, and you're convinced this is the diagnosis. Okay, now my job is to go and double check. Hello, Mr. Smith. Nice to meet you. I'm Ben Lovell. I'm the consultant. I've been hearing all about you from insert reference doctor's name here. I'm so sorry you've come into hospital. I understand you've had a nasty cough and we've diagnosed you with pneumonia. How are you feeling today? And you've been unwell for 2 days and you've been coughing and then you had a fever and here you are. And I rely on the patient to jump in and say, no, not 2 days, or no, that's not right. But I repeat the information to the patient in front of them and the resident doctor, just so everyone has a chance to go, no, you got the wrong end of the stick there. And do I miss stuff? Well, look at the case we're doing today. when you take a lot of things on trust, on faith, you have to sort of double check you think you're coming from the right diagnostic direction as the initial clerking doctor. But I find that I can't re-examine from scratch, not totally. I can't take history from scratch, not when there's so much to do. And this is the method I slowly developed over 8 years of being a consultant.
Okay.
So I find works for me most of the time. And that involves me sometimes going to the patient saying, hello, nice to meet you. I'm so sorry you've had to come into hospital. It looks as though you're very well, but we don't know what's going on yet. Have you got any ideas what could be going on? And being quite open about that sort of thing. And I change it from patient to patient, but that's how I move quickly through the post-sick ward. And for me, that won't suit a lot of people, but for me, it works.
I think you would really dislike my ward rounds. I'm like, okay, then say then, Mrs. Smith. Sit down, maybe hold their hand and say, tell me why you've come to hospital.
You're the fourth person to ask me
Sometimes.
to read the notes.
And then I'll ask them, well, what sort of work did you used to do? Well, I did, oh, that's lovely. Do you have any pets? I can see the resident doctors going, oh, God, she doesn't need to know about their pet rabbit.
It's when they stop typing. It's when you're talking to a patient and you can hear this tippy, 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 tappy behind you because they're writing down on their computer what you're saying. And it's when they stop typing, you think they're not writing this down because they think I've gone off on a tangent.
It's got even worse. I've banned computers on my ward rounds.
Why?
Because I find it really distracting for my excessive history taking.
So did your resident have to remember everything and then go out and write it all down again?
Now I have to do all my own notes.
Oh, wow.
Yeah, I know. I think I need to come and see how you work, Ben, because I have to type everything. I know.
Gosh.
Yeah,
I don't get anything done. Do check what they've written, but I can't, I can't be going to write it. Otherwise, what are they doing? They're just watching and learning?
No, I get them to examine the patients. I get them to talk to the patients. But yeah, it's painful. I need to change. It's crazy. Maybe I'll need to come and do like an elective with you 20 years after I qualify.
I'll leave that with you. I go back to the case. This is not the best case for me to promote the Ben Lovell system because it is the case where I really could have done with a bit of Amie Burbridging and examining the patient from scratch.
Maybe. Yeah. Somewhere in the middle, maybe.
There's a happy medium somewhere. We talk about bias, and I thought, well, here's an interesting bias. How often do we stereotype? And in what we think is even a positive way, as opposed to a negative way and having sort of prejudices against people, but it still doesn't turn out right. It still doesn't work. If the patient doesn't match your mental archetype for what this condition looks like. And boy, did this man not match the picture I had in my brain of an IVDU.
Wow.
So there you go. That's humanity for you.
Thank you. It was a really interesting conversation about the case, but also about how we do post takes and how we think, how we feel.
Yeah.
Fascinating.
And I think there is a balance to be struck between taking everything at face value and just saying, sorry, go back a bit. What was that last thing you said? I didn't catch about murmurs or not. You didn't mention it. Oh, okay. Well, we need to talk about it. And I thought this is a good illustration of that. Great. Well, thank you for listening to me drone on. And thank you everyone who listens as well. Wherever you're listening to us on any app, if you could click a few buttons on your phone and leave us a quick rating or a bit of feedback or a review, that'd be super, because that does something clever to algorithms and means we're more likely to be found when someone's searching for their next medical podcast they want to listen to. And of course, you can recommend us the old-fashioned way by just telling people face to face, hey, have you heard the Home of Medicine podcast? And we hope you enjoy listening and guessing along with us when we do these cases. Thanks so much for listening again, and it's goodbye from us.
Goodbye.